Well, now we've heard what causes the problems, and now we're going to hear what can result from those, from the weakness rather, and what tests are that can be done to identify those. And for that, we have Dr. Noah Lechtzin, who is director of the Neuromuscular Clinic in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins Hospital. He's assistant professor of medicine at the Johns Hopkins School of Medicine in Baltimore, Maryland. Dr. Lechtzin also treats people with ALS, post-polio, muscular dystrophy, spinal muscular atrophy, and is another neuromuscular expert. He has also published many articles on the effects of non-invasive ventilation in survival of people with ALS and on the care of adults with Duchenne's muscular dystrophy. He currently is vice chair of the Home Care Network of the American College of Chest Physicians, and we appreciate his coming out all this way to be with us today. Noah, thank you.
Well, thank you, and good afternoon. It's a pleasure to be at this remarkable institution. Thank you to Judith and Gladys for all of their hard work in organizing this. I don't think I've ever been part of a conference that the organizers were so diligent and hardworking to make sure everything was going to work out just right. So I think Dr. Sheehan's talk is a good segue into mine. I think there will be a little bit of overlap, and I'll try to move through things that are redundant quickly, but hopefully carry on into some of the questions that came up about symptoms and how to evaluate shortness of breath related to neuromuscular disease. And then after this, Louis Boitano and I are going to talk more about treatment. So I might say a few words during the next hour about treatment, but try to hold off on questions on treatment till the next talk, because I think we're going to cover most things. So as Judith said, home for me is Baltimore, Maryland. When I left, it was not nearly this sunny and warm out. It was drizzly and cold, so I'm very happy to be here. So a couple of the topics that I'm going to cover. First, just very briefly, sort of why is a pulmonologist up here talking about respiratory problems? And I think based on the fact that you've come to this conference, you're probably aware about the importance. One of my challenges is to cover what is potentially a very dry and boring topic for an hour and try to keep people awake. But I'm going to talk some about just basic pulmonary physiology, specifically about the respiratory muscles and respiratory mechanics, about gas exchange and control of ventilation. I'm going to touch a little bit on some of the specific disorders and how they are similar and differ from one another. Certainly not going to be a comprehensive talk of all the different potential problems that can come up, but just using a few disorders as models for others. And then I'm going to talk about the presentation and evaluation of respiratory and sleep problems in patients with neuromuscular diseases. So as a pulmonologist, why am I interested in neuromuscular disease? Why am I here? So clearly the respiratory complications in neuromuscular disease are the leading causes of morbidity and mortality. Patients can go on to develop infections, so lung infections are what we call pneumonia. I'll probably use the word atelectasis a number of times through this talk, and atelectasis is just a fancy word for collapse of air sacs. Respiratory failure, which can either be an abnormally low oxygen level or an abnormally high carbon dioxide level in the blood, and sleep apnea, which I'll go into a lot more detail, but can be broken down in several ways and can result in fatigue and a number of other complications. So I said neuromuscular problems, the respiratory problems related to neuromuscular disease are important. We have lots of data to back that up. This is just one, just using ALS or Lou Gehrig's disease as a model. So looking at all patients hospitalized with Lou Gehrig's disease, the number one cause is acute respiratory failure. Number two is aspiration pneumonitis, which simply means inflammation or infection from inhaling stomach contents, and just other causes of pneumonia. So there are a number of causes of respiratory complications from neuromuscular disease. In general, as you just heard, they're due to weakness of the breathing muscles, which prohibits or limits people's ability to inhale fully. Also, the inability to cough, which leads to difficulty clearing secretions. So the lungs and airways throughout the day make a certain amount of mucus, and you need to be able to cough and clear those out. And then also impaired swallowing is an important issue, which I'll talk more about. And all of these things lead to the risk for hypoventilation, mucus plugging, so if those secretions don't get coughed out, they can become thick and block the airways. Aspiration, so if you have trouble swallowing, it puts you at more risk for having food go down into the windpipe and cause an infection. And then sleep apnea. So moving on to what I like to call Pulmonary Physiology 101. So the main function of our respiratory system is essentially to get oxygen into the lungs and blood, and the body produces carbon dioxide, and by breathing, you blow carbon dioxide out. And ventilation, which the word has come up a couple times already, is simply just moving air and gas in and out of the lungs. It has a number of smaller, less relevant functions, but one of the things that you need your lungs and respiratory muscles to do is to enable you to speak. So speech, in order to speak, air moves out of the windpipe through the vocal cords that are in the neck, causes those vocal cords to vibrate and form speech. So if you can't forcefully move air out or control the vocal cords well, you can't speak. Okay. And as the American Lung Association likes to say, when you can't breathe, nothing else matters. So the airway anatomy. So the respiratory system in airways really includes everything from the nose on down to the alveoli or air sacs. So it's the nasal cavity, the pharynx, the epiglottis and larynx. So the larynx is the vocal cords here. And then the lower airways. So you've got the trachea or windpipe, which then branches out like a tree into smaller and smaller airways and eventually gets down to the alveoli. So this is a microscopic picture of the alveoli, and it's this very fine network of tiny little air sacs. When blown up, they look like clusters of grapes, but they are microscopic, and they're sort of like a balloon that if you don't tie the balloon, it has elasticity and wants to close down. And so the air sacs, if given the chance, collapse down and close. So we already heard a little bit about the respiratory muscles. Just to go into a little bit more detail, there's separate muscles that you use to inhale, the inspiratory muscles, and there's separate ones you use to exhale. So the inspiratory muscles, primarily, the most important one, as we heard, is the diaphragm. Some people will call it dome-shaped. Here it says it's shaped like a parachute, but it's underneath the rib cage. And when you inhale, it moves down and out and lifts the rib cage, enlarges it, and allows air to come into the lungs. There's also what we call accessory muscles that are muscles between the ribs and up in the neck that help the diaphragm. But the diaphragm really does about 80% of the work when you inhale. So clearly, if the diaphragm isn't working, people are going to run into problems. Just another picture. Well, let's see. Just showing some of the accessory muscles. So there's these muscles between the ribs that help lift the rib cage up, and also muscles up in the neck that help raise the rib cage. And I'll talk a little bit about those accessory muscles when I'm talking about diagnosing and evaluating patients. And then there's the expiratory muscles. So generally, if you're just breathing quietly, as I said, the lungs are elastic like balloons. They want to get back down to their original size. So if you inhale, they expand, and if you just relax, they go back to their normal size. So at rest, and when you're just breathing quietly, expiration is largely passive. But if you want to speak loudly or yell or cough, you use abdominal muscles largely to forcefully exhale. So if the abdominal muscles become weak, the cough becomes weak. So here we have Al Gore saying it's all about carbon dioxide emissions. So he knows all about the ventilation and control of breathing. This is a topic that I'm going to take a little bit of time on. Inevitably, it gets confusing, so bear with me and hopefully it'll be clear. So we heard a little bit about the brainstem and how there's sensors in the brainstem that are responsible for controlling breathing. So let's see, I think I might have a picture here similar to the one we just saw. So this area down at the base of the brain is called the brainstem, and there's sensors in the brainstem that respond to carbon dioxide. As I said, the body naturally produces carbon dioxide, and the lungs, when you exhale, blow out carbon dioxide. And the body is very sensitive to controlling levels of carbon dioxide. This just shows, so if carbon dioxide levels rise, those sensors say, oh, carbon dioxide's too high, I've got to breathe faster and deeper and get the carbon dioxide back down. This is just a graph showing in an experimental condition what happens to, this is minute ventilation, which is essentially just saying how much air is going in and out of the lungs and airways at a time, and this is carbon dioxide, and it just shows that if this is normal, a normal carbon dioxide level is about 40, you can see the minute ventilation is here, and as carbon dioxide levels rise, the body's reaction is to increase ventilation, breathe deeper and faster. There's also some control of breathing based on oxygen levels. So it's located in different areas. So the receptors for oxygen are in the carotid body, so along the carotid artery in the neck. They tend not to be as important or sensitive as the sensors that respond to carbon dioxide. And what they respond to is, as you would think, as makes sense, low oxygen level. So if the oxygen level in the body falls, those sensors fire and tell your body you need to breathe more, you're not getting enough oxygen. But what can happen, so certain people just have a blunted response to carbon dioxide. Their body doesn't have that correct response, and as carbon dioxide levels rise, those sensors don't fire and tell the body to breathe more. Also, people with neuromuscular disease who tend to underventilate, their muscles are weak, they're not able to move enough air in and out, carbon dioxide levels can gradually rise, and those sensors eventually get used to it and say, well, I'm doing okay with this carbon dioxide level that's 50, I'm not going to do anything about it. And so people with these chronically elevated carbon dioxide levels may only respond to falls in oxygen. So in those cases, they're sort of dependent on these sensors that respond to oxygen, and so if the oxygen level falls, then their body says, oh, got to breathe more. And why I'm pointing this out is because people often get into trouble because they come to their doctor for a number of reasons. One is they come to their doctor and say, you know, I'm feeling short of breath, I think I might need some oxygen, and doctors in general say, oh, yeah, I think if you're short of breath, oxygen will probably do you some good, and get started on supplemental oxygen and raise their oxygen level, and all of a sudden they're no longer responding to those low oxygen levels and breathe even less and run into more problems with their carbon dioxide level rising. Also acutely, so this is just showing paramedics attending to a patient, and one of the first responses paramedics usually have when they see somebody is looking uncomfortable, not breathing well, is unconscious, is they put on an oxygen mask and give them lots of oxygen. And in most cases, that's the right thing to do. But in patients with neuromuscular disease who no longer respond to high carbon dioxide levels and rely on sensing low oxygen, all of a sudden their oxygen level goes up and they actually stop breathing or breathe even less than they had been. And again, their carbon dioxide level can go up. And when the carbon dioxide level goes up too high, people can slip into a coma. So I'm sure this probably, every time I talk about this, it generates more questions, so I'll certainly be happy to field those afterwards. So a few words about coughing. So coughing, most of the time people think of this as an annoying symptom that they want to get rid of, but cough can actually be a very important mechanism for clearing respiratory secretions, avoiding mucus plugging, and avoiding infections. And coughing effectively is actually a fairly complicated process that we generally don't think about, but it requires adequate inspiratory muscles, expiratory muscles, and what I'm calling the bulbar muscles, so the muscles of the mouth, the throat, the larynx to occur properly. So these are the vocal cords. When you breathe in and out, those vocal cords need to be open. When you speak, they close and allow vibration. They also close, as I'll show you, during coughing. So there's three phases to the cough: the inspiratory phase, the compressive phase, and the expulsive phase. There's a lot, as I mentioned, as I said, coughing is a fairly complicated maneuver that you need the correct nerves to be intact. You need This is the glottis. You need it to be functioning properly. You need the muscles to be functioning properly. And your chest wall needs to be able to expand normally. So in the inspiratory phase, you take in a deep breath. The vocal cords are open. This, as I mentioned, again, lungs are like a balloon. You want to inflate that balloon so that it's going to squeeze the air out. Whenever you fill up your lungs, also the airways get pulled along and open up, and the abdominal muscles are stretched and ready to squeeze and contract. Then you have this compressive phase where you build up a lot of pressure to cough. And so those vocal cords, the glottis closes, the expiratory muscles contract, and it generates this big pressure inside the chest. And then you have the expulsive phase, which is where you actually hear the cough. So the vocal cords open, the abdominal muscles continue to squeeze, and a huge expiratory flow of air blasts out and hopefully clears whatever's down in the airways. A few words about sleep disorder breathing. So we've already had a few questions about sleep apnea and snoring. And so this is a picture of somebody, or a cartoon of somebody lying down. This is their nose. This is the chin, just to get some orientation here. There's teeth. And this is the tongue. And you can see down here is the trachea, or the windpipe. And at times, the muscles of the tongue and the posterior pharynx can fall back and essentially block off this airway. And so sleep apnea essentially means the cessation or stopping of breathing when you're asleep. This can be this can be classified as obstructive sleep apnea. So this would be an example of obstructive sleep apnea where the airway is actually blocked. There can be central apnea where the airway isn't blocked, but there's no signal coming from up in the brain saying breathe, so people just stop and don't try to breathe. And then there's also mixed, where you have some component of obstruction and also a lack of signal from above saying breathe. Sleep apnea can cause a lot of problems. So we often just think we get worried about people complaining of fatigue and being sleepy, but more and more we're finding that sleep apnea can cause all sorts of more systemic problems. So it can cause high blood pressure, hypertension. There may be some association with causing diabetes. It can cause what we call pulmonary hypertension, which is high blood pressure in the lungs. It can be a very problematic issue. And certainly it can make people sleepy. So there's lots of cases of truck drivers driving across the country and falling asleep and getting into accidents. So we certainly worry about these things. Risks for sleep apnea. So unfortunately, obesity is a huge epidemic in this country and only getting worse. So obesity is probably the biggest risk for sleep apnea. But as people get older, the muscles in the airway tend to get a little more floppy, and some of the drive for breathing can sometimes decrease. Men, for whatever reason, are at increased risk, independent of obesity. But then certainly neuromuscular disease can predispose people to sleep apnea. So if you have weakness of the pharyngeal muscles, so these muscles of the tongue and the upper airway, it, I think, is not too much of a stretch to see how that could predispose those muscles from collapsing and blocking the airway. And then also, for reasons that are less clear, some neuromuscular disorders seem to cause just an abnormal respiratory drive and can lead to central sleep apnea. So here is Oscar the Grouch from Sesame Street. And I don't think he was part of it, but I just remember growing up watching Sesame Street, and they always did this song, "One of these things is not like the others." So this is my opportunity to compare and contrast some of the different neuromuscular disorders as they specifically relate to breathing issues. So I'm just going to say a few words. Don't want to be redundant with what Dr. Sheehan just covered, but so Lou Gehrig's disease affects about 30,000 people in the U.S., tends to affect an older population. We don't really know what causes it, and it tends to be a fairly rapidly progressing disorder. So median survival from the time of diagnosis is somewhere around 3 to 5 years. But there is a lot of variation. So as Dr. Sheehan showed, you have somebody like Stephen Hawking who's had it for years and years and years and doesn't seem to be progressing. But certainly the more typical patient progresses really fairly rapidly over a period of a few years. and most patients go on to die from respiratory complications. This is just what we heard about before about anterior horn cells. But one of the prominent features with ALS is that patients eventually get bulbar involvement, so they have problems speaking, dysarthria, and dysphagia, problems swallowing. Muscular dystrophy, again, not to be redundant, but it's a hereditary disorder. Duchenne's muscular dystrophy is the most common. And about 3/4 of patients with Duchenne muscular dystrophy die by age 25. They tend to have much less involvement of ocular, facial, and bulbar muscles than in ALS, which becomes relevant for how we manage patients with muscular dystrophy. Non-invasive ventilation, as we're going to talk about in the next hour, can be very effective for correcting hypercapnia, or another word for elevated carbon dioxide levels, and can certainly prolong survival. Some of the issues specific to muscular dystrophy with regards to the respiratory muscle is respiratory muscle weakness tends to develop somewhere between age 10 and 20, and the vital capacity tends to fall at a fairly predictable rate, somewhere around 8% per year. Again, the major causes of morbidity and mortality tend to be respiratory failure and infections. But interestingly, the respiratory symptoms, when compared to something like ALS, tend to be much more subtle. I have a lot of patients who are in their 20s, have muscular dystrophy, have very little respiratory function whatsoever, but you ask them, are you feeling short of breath? Is anything that you do seem to make you more short of breath? And a lot of them will just say, no, I feel fine. Whereas, and that's sometimes the case with things like Lou Gehrig's disease, but more often than not, patients will come in and tell you that they're short of breath, and I'll go into more details about symptoms, but they tend to notice it a little bit more. Post-polio syndrome, so again, tends to, it's recurrence of weakness in polio survivors, somewhere around 30 years after their initial problems. They develop respiratory muscle weakness, often in muscles that were previously affected. So when we're talking about respiratory muscles, it tends to be people who had respiratory problems with their initial disease, but not necessarily. Fatigue is a huge symptom. Muscle atrophy can occur. There's lots of issues with muscle and joint pain. And sleep apnea seems to be very common. I think I had it on my slide, but didn't mention it. So ALS, while people can have sleep apnea, tends to be a less common feature, whereas in post-polio, it's much more common. So this is just a table, and I didn't mention anything about it, but we heard in Dr. Sheehan's talk about diaphragm paralysis, so either from trauma or autoimmune issues, the diaphragm the phrenic nerves can be affected independent of anything else, and you can have just diaphragm paralysis as a contrast. So I have up here inspiratory weakness, expiratory weakness, impaired swallowing, and sleep apnea. So in something like ALS, you get both inspiratory and expiratory muscle weakness, not necessarily at the same time, which can make diagnosis a little more challenging. Inevitably, you have problems with the bulbar muscles and swallowing, and sleep apnea can be somewhat variable. Muscular dystrophy, inevitably you get inspiratory and expiratory muscle weakness. The bulbar disease tends to be much less of an issue, and sleep apnea, again, tends to be somewhat variable. Post-polio, involvement of the respiratory muscles is highly variable. Issues with bulbar muscle also variable, but sleep apnea tends to be more common. And then with diaphragm paralysis as a comparator, it's really just inspiratory muscle weakness and really no problems with the other systems. So moving on to sort of the practical issues with evaluation and approaching how to treat these patients without getting into a lot of the specifics of treatment just yet. So it's really critical to look out for these things and try to recognize the nature of respiratory impairment. And it's one of those things that there's a lot of good clinicians out there that are tuned into some of the neurologic issues. There's others that are tuned into cardiac issues. But a lot of times these respiratory issues sort of fall between the cracks. And if you're not thinking about them and aware of them and knowledgeable about them, you can certainly run into problems. It's important to be proactive and when issues arise, start non-invasive respiratory protocols early with the hope that recognition and intervention is going to avoid some of the complications that can occur down the road and the need for more urgent and invasive interventions. So I like to describe sort of a three-tiered approach to the respiratory care. One is sort of identification of the problems and then avoiding and eliminating things that we can avoid. Next is the ongoing evaluation. So after an initial evaluation, patients should come back and be reevaluated on a regular basis. And then the use of respiratory aids, which is going to come up in the next talk, which is going to include ventilatory support, airway clearance, lung volume recruitment. Okay. And so this is really going to focus on the evaluation. So one thing with regards to prevention is sort of common sense. Here's one of my daughters showing a good hand washing technique. So obviously we are in the influenza season, and so I think everybody's aware of the importance of infection control and avoiding infection. So while there's little data to say getting a flu vaccine and a pneumonia vaccine changes outcomes, it certainly makes sense that if you're going to avoid infections, it's worth getting an influenza vaccine once a year. In this case, getting a seasonal influenza and a swine flu vaccination, and also getting a pneumococcal vaccine. So pneumococcus is the most common cause of community-acquired pneumonia. Generally, you need it somewhere around every 5 to 6 years. So again, common sense, sort of avoiding people who are clearly sick, and optimizing nutrition and avoiding aspiration or choking. And so with this, it can be, part of it is just being aware that this is a potential problem and things can be done to avoid it. So sometimes simple things like changing the consistency of food and learning various swallowing techniques can go a long way to helping with nutrition. And certainly if swallowing and choking is becoming a prominent problem, using feeding tubes can be very helpful. I take care of a lot of different patient populations. I take care of a lot of adults with cystic fibrosis. They run into problems with nutrition, and sometimes we recommend feeding tubes. And I'll say in that population, patients tend to be miserable about getting a feeding tube. We put them in, they have a lot of pain at the site, they don't like to use them, and I would say more often than not, we wind up taking the feeding tube out shortly after it goes in. Neuromuscular patients tend to be just the opposite. They have a lot of patients will have anxiety about eating. Meals have become a challenge. They're time consuming. They don't have an appetite. Taking medications is difficult. And often putting in a feeding tube alleviates all of that, and they're very happy to be able to make sure that they're getting adequate nutrition, they're avoiding dehydration, they can take their medicines and avoid all of that stress. And they don't seem to have a lot of the pain and complications that some of my young patients with cystic fibrosis run into. So it's very different, and I would say almost 100% patients, once they have, sometimes they hear about it and say, oh, that sounds like a horrible thing, I don't want a feeding tube. And by and large, they're grateful once they've had it put in. So what to expect during a pulmonary visit? So certainly one of the first things is just talking about what problems have come up and looking for symptoms. Physical exam. So as I mentioned, we talk about these accessory muscles and the diaphragm. And so very simple, just looking at a patient and seeing what muscles they're using as they breathe can be very helpful to identify weakness of the diaphragm. Listen to the lungs, listening for both how well air is moving in and out of the lungs, and then listening for any signs of congestion or an infection. We'll almost inevitably do some pulmonary function tests, which I'm going to go into a lot of detail about. And then talk about some of the different treatments that are available. Certainly, as a lot of these patients, as I mentioned, die of respiratory complications, it's very important to be proactive, talk about what patients' wishes are. If they get to a point where they can't tolerate non-invasive ventilation, would they want a tracheostomy and long-term invasive ventilation? And then also, we're involved in a lot of research projects, and I think patients are often very happy to hear about various research protocols that are ongoing and like to be involved. So when it comes to identifying problems and asking about symptoms, as I mentioned, sometimes the symptoms can be very subtle. Certainly, some patients will tell you, I'm feeling short of breath. I'm short of breath when I do activities. But frequently, some of the patients patients with muscular dystrophy who are in wheelchairs and really have very severe limb weakness don't do much to exert themselves, and the problems have crept up so gradually over so many years, they may not notice that they're short of breath. But classically and often, patients will notice that they're more short of breath if they lie flat or if they submerge themselves in water above the waist. So we have some patients who will do water aerobics and water physical therapy and notice problems. And this is because the diaphragm, which sits down below the rib cage, when you lie on your back, all the abdominal contents push up against the diaphragm, and it's kind of a bit of a stressor on the diaphragm. The same thing happens when you go in water. Everything pushes, and the abdomen pushes up against the diaphragm and makes it more difficult to breathe. Sometimes people will tell me they're more short of breath after they eat a large meal. So again, the stomach sits under the diaphragm, and if it's distended and full from a big meal, it can impair breathing. Sometimes people will just tell me, oh, I'm having more headaches. Why is that? Or I'm waking up more frequently at night, or I'm feeling that I'm tired and fatigued during the day. And all of these can be problems with sleeping. Sometimes people often come up with, try to justify why they're waking up without realizing that it's related to their breathing. So they may say, oh, I have to urinate more often, or I'm just having a more difficult time getting comfortable, and that's what's waking me up. So you have to be suspicious and look for some of these subtle breathing problems at night. And frequently people just tell me, I just don't feel like I can take as deep a breath as I would like to, or I can't cough as well as I once did. So here you have a person in surgery, and the surgeon says, oh, sorry to wake you up, but you were snoring. So certainly, we hear a lot about snoring and sleep apnea, and snoring is one of the more common symptoms of sleep apnea. Certainly people can snore and not have sleep apnea, and people can have sleep apnea and not snore, but snoring can be one clue that sleep apnea may be an issue. Another thing that sometimes people will tell me is, oh, so-and-so might, often it's the partner or spouse of a patient who knows about snoring, because obviously if the person is snoring, they're probably asleep, but their bed partner may say, so-and-so used to sleep, or used to snore, but now they're not, and that can actually be a concerning symptom, that if they're not moving enough air when they're sleeping, that snoring that once used to be a big problem has gone away. So so these tend to be sort of acute problems, but symptoms of respiratory infection to look out for are a feeling of chest congestion, fevers, chills, chest pain, especially with taking a deep breath or coughing, and then new development of cough and phlegm. Let's see, so other respiratory symptoms. So as I mentioned, dyspnea is just a fancy word for shortness of breath. Orthopnea is shortness of breath when lying down. Complaints of weak cough, increases in mucus and secretions. And not surprisingly, I'm going to talk about pulmonary function tests, but having shortness of breath is associated with worse pulmonary function tests. I'm not, for the sake of time and boredom, I'm not going to go through some of these busy graphs and tables. So when it comes to the evaluation, as I mentioned, I do physical exam, looking for abnormal use of accessory muscles, signs that the diaphragm isn't moving well, go on to pulmonary function tests, and potentially sleep testing. So ideally, we want to use tests that are readily available, give us objective measures, and things that we can do repeatedly without too much difficulty. It's kind of saying the same thing. So some of these objective measures that we frequently use. So pulmonary function tests, and I'm going to go through these in much more detail. So spirometry, both sitting upright and lying supine. MIP, which stands for maximal inspiratory pressure, and MEP, which stands for maximal expiratory pressure. We can measure gas exchange, so delivery of oxygen and exhaling carbon dioxide through a number of methods. One is through a blood test called an arterial blood gas. Another is oxygen saturation, and another is capnography. We can do sort of more invasive tests if needed, so we can directly measure how well the diaphragm is moving and how well how much pressure your abdominal muscles are generating to cough. We can measure cough flows to see how well somebody is coughing. I'll talk about sniff nasal pressures, and I'll talk about sleep studies. It's worth noting that in ALS, as an example, essentially all of these different pulmonary function tests have been shown to be predictive of survival, whereas some of these more difficult or invasive measures of gas exchange tend not to be as useful, and partly it's because by the time somebody's having problems with gas exchange, having a low oxygen level or an elevated carbon dioxide level, it tends to be a fairly sudden and late occurrence. So we really shouldn't be necessarily pinning a lot on measuring oxygen and carbon dioxide, at least as a screening measure, because if that's what you're waiting to see, you're going to miss a lot more early problems. So pulmonary function testing can be very useful for following the course of disease, for diagnosing respiratory muscle involvement, and for helping to time various interventions that we're going to talk more about, such as ventilation, ventilatory support, placing feeding tubes, deciding whether somebody needs oxygen. And this is one of the more common questions I get. Is somebody comes in, they tell me they're short of breath, they have respiratory muscle weakness, and they say, do I need oxygen? And most of the time, the answer is no. Occasionally, there are people that either have some underlying lung disease, like emphysema, which reduces their oxygen levels, or they're going to travel and they have sort of marginal oxygen levels at sea level, and when they're up in a plane cabin at a lower pressure, they may need oxygen. But rarely is oxygen the one solution. So spirometry is what we do most commonly. And this is just a diagram showing what spirometry actually is. So here's a patient blowing through a tube. Most of the modern spirometers that you see, you're not going to see anything that looks like this is a water-filled jar with essentially an empty upside-down container over it. And when you blow in, the container is displaced, and it moves a pen on a piece of paper, and you can measure the volumes of air that somebody blows out. Nowadays, this is generally all electronic, and there's flow sensors that can measure the airflow and then extrapolate and come up with these volumes. But essentially what we're most interested in or pay the most attention to is what's called the force of vital capacity, or the vital capacity. And that's essentially, or simply, the total amount of air that you blow out from a full breath in. And often it gets reported as this percent of predicted. And so what does this number mean? Often patients will come in and say, oh yeah, I saw somebody and they told me my breathing was 45% of, my breathing was 45%. What that means is we have extensive experience measuring vital capacities in normal, healthy volunteers. And for a given age, height, and gender, we know what somebody's lung function ought to be. And so when we measure somebody's vital capacity in the clinic, we then compare it to what we'd expect from a normal, healthy volunteer and come up with some percentage of predicted. Again, this is a readily available test. Lots of primary care physicians have spirometers in their offices. Every hospital essentially has a pulmonary function lab, so it's easy. There's small handheld meters that can be used, so it's really an easy test to measure. We have lots of experience with it, so it's one of the more useful things to do at every visit. This is just showing lung function, vital capacity over time in a series of patients with ALS, or Lou Gehrig's disease, and what it shows is that, as I mentioned, ALS tends to be highly variable. Some patients over time deteriorate very quickly, whereas others, and this is over about 50 or 60 months, you can see this person went down much more gradually. So it can be very good as you collect 2 or 3 measurements, you can get a very good sense of how somebody is progressing. Skip over that. So another measure, the maximal inspiratory pressure, or MIP, goes by several different names that some people will call it a NIF, or negative inspiratory force. And essentially it's a global measure of inspiratory function. So you have somebody breathe through a mouthpiece and you close off, you block off the airway, and have them suck in as hard as they can, and you just measure how much pressure can be generated. The one challenge with it is it's something of an awkward maneuver, very effort dependent, and because you have to suck in real hard with this awkward mouthpiece in your mouth. If you have weakness of the mouth muscles, it can be very difficult for people to do well without having lots of air leaking everywhere. So we get slightly more variable measurements that are sometimes a little bit harder to interpret. One thing of note when we're talking about starting people on non-invasive ventilation, patients want and need insurance to be able to cover their equipment. Medicare guidelines often dictate this, and the criteria for the maximum inspiratory pressure is fairly lenient, and it's generally a pretty easy measure to get people to meet their requirements. This is something we don't do a lot. It's not available that widely, but sometimes if we want a very precise measurement of diaphragm function, you can do what's called, you can directly measure the transdiaphragmatic pressure. So you put in a catheter with balloons on the end, one that sits in the stomach and one that sits above the diaphragm in the esophagus, and you have people sniff in as hard as they can, and you measure the amount of pressure that's generated across the diaphragm. I will say, again, we don't use it very often because patients, understandably, don't like to have balloons put into their stomach. Yeah, I see that people understand that one. But fortunately, there is an alternative, less invasive maneuver that seems to be pretty darn good, and that's called the sniff nasal inspiratory pressure, or the SNP. And you can see you put a plug on the end of a tube and just place it in the nostril and have people inhale. It's nice in that you don't have to be able to form a good seal with the mouth. So as I mentioned with MIP, and I didn't mention it with spirometry, but it's true with spirometry as well, that you need to be able to form a good seal with the mouth. With the SNP, you don't have to be able to form a good seal. Sniffing in is a fairly natural maneuver that people can do pretty reproducibly, and you get measures that are pretty close to the invasive transdiaphragmatic pressure. This is just showing in a series of ALS patients comparing vital capacity, the maximum inspiratory pressure or force, and this SNP measurement. You can see people who did it, people who were unable to do it in the columns next to it, and there were certainly more people who couldn't do vital capacities, couldn't do MIPS, but relatively few that couldn't do the SNP maneuver. And you got measurements that were more reproducible and similar to vital capacity, also were predictive of survival. So it seems to be a good measurement that I think is catching on. It seems to have caught on more in Europe than in the US, but I think we're going to be seeing more and more of it. So those were either sort of global measures of inspiratory force or more reflective of inspiratory ability. As I mentioned, a lot of these disorders also result in expiratory muscle weakness, and it's important to be able to measure expiratory function. So one of them is with measuring the MEP, or maximal expiratory pressure, which is the same thing as the MIP, where you suck in, but it's the opposite. You just have people blow out as hard as they can, and you measure how much pressure they can generate. Again, tends to be a little bit awkward and can be a little bit difficult in patients who have weakness of the mouth muscles. The cough peak flow, so this is asthmatics, people with asthma often are asked to measure their peak flow to monitor their asthma severity. So these peak flow meters are easy to come by, and if you put a face mask on it and have people cough into it, you can measure how much flow they can generate when they cough. And it's been shown that you need to be able to generate about 160 liters per minute to clear secretions. And it's also been shown that if somebody is acutely sick, if they have pneumonia or some other illness, their peak flows tend to be reduced. And so it can be a good screening measure to determine when people need assistance with clearing secretions. So when the cough peak flow gets down below 270, it can be used as a trigger to initiate assisted cough techniques that we'll talk more about. Let's skip that. Okay, so here we've moved from Sesame Street onto ET. And here ET is showing how you can measure his oxygen saturation with a little finger probe. So it's important, though I said as a screening test, measuring gas exchange or oxygen levels and CO2 is not necessarily the best way to go. It's certainly important to know something about oxygen levels and CO2. So the gold standard is by measuring blood directly from an artery with an arterial blood gas. So you stick a needle most commonly into the radial artery in the wrist, and you can directly measure arterial oxygen and CO2. So it's a quick and accurate measurement, but it's somewhat painful. If patients have limb contractures, it can be a real challenge to try to get one of these measurements. And generally, it's done in a hospital during the daytime, so it's not necessarily reflective of what's happening at night. Pulse oximetry is a great way to measure oxygen levels. So it's accurate, it's non-invasive, you can measure continuous levels. So very handy. Small handheld meters are now fairly inexpensive, so patients can use them in their home. The one thing that's lacking is it doesn't tell you anything about carbon dioxide. So sometimes you can get a false sense of security and say, oh, their oxygen level's fine, and miss some fairly profound hypoventilation. So as I said, so these are examples of pulse oximeters. This is a very small handheld unit. This is just a probe. And so it can be, another thing, as I mentioned, patients can keep them in their home, and by using them at home on a regular basis, it can be a great indicator of some impending problems. So if patients measure their pulse ox regularly and know that it's normally in the mid-90s, if all of a sudden it drops, it should be a trigger to say, oh, something's wrong, and frequently that can be that they're having atelectasis or collapse of air sacs or mucus plugging, and they ought to increase their ventilation and cough and assisted coughing techniques. It can also be used overnight to detect sleep-disordered breathing. So more and more of these pulse oximeters have memory cards, and they can store data overnight, and you can download it, look back, and see if patients are running into problems while they're sleeping. Capnography, or measurement of end-tidal CO2, that's measuring the CO2 that's present at the end of exhalation, is non-invasive, it's convenient, tends to not be as accurate as arterial blood gases. The monitors are still fairly expensive and not as widely available as pulse oximetry. So it's something that in the clinic we do, but hasn't quite made it to sort of widespread home use yet. So I'm going to get to sleep studies. So I'm not sure whether it will come across in my talking. So sleep labs are generally run by either pulmonologists or neurologists. And it's become a fairly specialized area where there's some people that's the majority of what they do is sleep medicine. I'm not one of those people, and my bias tends to be against using sleep studies a lot. With that said, they can be important, and I'm going to try not to put my own biases too much into this. So sleep studies can be useful to diagnose sleep-disordered breathing. So as I talked about before, obstructive sleep apnea, central sleep apnea, mixed apneas. And they can also be used to initiate and adjust non-invasive ventilation. So what is polysomnography, and what do we measure? So there's a lot of variations, but you'll see there's a lot of different parameters that are measured. So in that way, it can be very useful for giving a lot of detailed physiologic information about what's going on with people when they sleep. So you have EEGs, or monitors of brain wave function. You have EOGs, or electroculograms, so measuring eye movements, EMGs, measuring chin and leg and intercostal muscle function, activity, EKGs, so cardiograms, so monitoring cardiac function throughout. You have respiratory monitors, so you monitor airflow, you monitor chest and abdominal movement. Sometimes people will put in esophageal balloons and measure pressure inside the esophagus, and then oxygen saturations and CO2 levels. So, so somebody who's undergoing a sleep study, this is a sort of a typical picture where you can see they're lying in a bed but hooked up to lots of different wires, measuring all of these different activities. And one of the most common things I hear is, oh yeah, I had a sleep study, but I didn't really sleep. So you take somebody, you put them in an unfamiliar, uncomfortable room, hook them up to lots of things, and then tell them to sleep, and hope that that's reflective of what's going on at home. So sleep doctors will often say, oh, you know, they slept for 2 hours. That's fine, that we got the information we wanted. But patients will certainly say, oh, that really wasn't how I sleep. I never sleep on my back. I always sleep on my side. This, you know, isn't really reflective of what's going on. But I think certainly in the right circumstances, you can get a lot of useful information. So some of the pros, so as I said, you really get a lot of detailed physiologic information. So doing home pulse oximetry can be useful for screening and seeing whether somebody's oxygen levels are falling at night. But if they're not falling, you can be reassured and say, oh, they're probably doing pretty well. But if they are falling, it doesn't tell you a lot about why that's happening. They can accurately diagnose and differentiate various causes of sleep disordered breathing. So are they having obstructive sleep apnea? Are they having central sleep apnea? Are they having a mix? And they can be very helpful for titrating non-invasive ventilation and accurately measuring how patients are responding. One caveat, because sleep apnea is so common, a lot of sleep centers are very focused on obesity and obstructive sleep apnea and know much less about the complications of neuromuscular disease. And so I've often seen people go to sleep labs and get put on various strange settings for their non-invasive ventilation because the sleep techs sort of think, oh, their oxygen level's falling, they must be having apnea, we're just going to crank up some strange settings, and sometimes it can be more detrimental than helpful. So that goes in the cons. So a lot of labs aren't really well equipped for people with disabilities. This can be a real challenge, especially patients who are fairly sick. Sometimes going into a sleep lab can be quite an ordeal. As I mentioned, sleep medicine these days is very focused on obstructive sleep apnea and not so much on neuromuscular disease. Clearly this varies a lot. There are some places where the people have a lot of knowledge of neuromuscular disease and are very good at this. They may not recognize hypoventilation, so measuring CO2 levels is not something that widely done. They tend to be focused much more on drops in oxygen saturation. And as I mentioned, they might not be familiar with titrating non-invasive ventilation for patients with ventilatory problems and neuromuscular disease. As I mentioned, so going into a sleep lab can be quite an ordeal, and patients often don't sleep. Home polysomnography, or home sleep studies, is certainly becoming more common. One of the challenges, generally you don't measure quite as many parameters. There's less standardization, but it is much more convenient for patients. And as I mentioned, overnight oximetry may be a poor man's solution to doing formal sleep studies. So getting towards the end, hopefully people have stayed awake. So what do I like to do on follow-up visits? So again, sort of talk to patients, find out what's crept up since their last visit. Are they having any more trouble with clearing secretions or buildup of phlegm? Are they having headaches when they didn't? Are they feeling sleepy or fatigued? Continue discussions about ventilatory support. If they're using BiPAP, how is it working for them? Do we need to make some adjustments? If they haven't been using it, is it time to start? Talk more about secretion clearance, and again, keep revisiting same old issues about advanced directives. Has anything changed? So this, I don't expect anybody to actually be able to read it. This was an algorithm that I had come up with for evaluating and treating patients with ALS, and to some extent it's generalizable to other disorders. So up at the top it says take a history and physical exam every 3 months, do spirometry both upright and supine every 3 months, and when the vital capacity begins to fall, and this number can be debated, but I have here 50%, start thinking about non-invasive ventilation. Over here, when interviewing patients, are they having sleep difficulties, or are they excessively tired? Might be time to think about doing an overnight oximetry or getting a sleep study. Are they having difficulty with secretions, or is their cough peak flow abnormally low? If so, let's start mechanical insufflation-exsufflation, which you'll hear more about shortly. Are they short of breath when they lie down? Are they having morning headaches? Are they using accessory muscles, or is their diaphragm moving abnormally? If so, let's do some further tests. We might do a maximum inspiratory pressure. We might measure their arterial blood gas. And if those are abnormal, think about non-invasive ventilation. Once they've been using non-invasive ventilation, are they tolerating it? If not, is it because of secretions? And so if somebody's gotten to a point where they've not tolerating non-invasive ventilation or running into problems with secretions that we can't control, and we start to think about invasive ventilation. So to wrap things up, it's important to identify people who are knowledgeable about the respiratory care of neuromuscular patients. It's important to have somebody that's accessible. The respiratory care providers are really the people that sort of are right on the front lines and seeing the patients on an ongoing basis, and they're probably the most important people involved. There are a wide variety of readily available tests that we can use, but it's important to know kind of which to start with and which ones are most useful and where some of the problems and pitfalls lie. And certainly, proper evaluation will lead to various important multiple life-altering therapies that I think are highly beneficial. And I'm going to stop there, which happens to be sunset over the Pacific, but not here. So it looks like we've got some questions, so we can get the microphone passed around.
I'm a veteran, and when I've had sleep study done both at the Los Angeles and locally, when my doctor sent me for the pulmonary test, nothing was ever done lying down. It was always sitting up in the booth, and I always turned out fine. Mm-hmm. But so they couldn't understand my being short of breath and all. But I had been reading in one of the Post-Polio papers about should be, lying flat. They should test us. So what do? We asked our doctor to... Yeah,
I would certainly ask the doctor who's ordering the pulmonary test, suggested. I think, it's one of those things that's becoming more widely done, but certainly not something that everybody's familiar with or thinks of. So.
I have post-polio, and I have a question about sleep studies. Mm-hmm. When I was first diagnosed, the post-polio specialist said absolutely you have to have a sleep study. That's just a baseline thing. And I needed non-invasive ventilation. My question is, you made the comment that sleep studies are not necessary, that there are other studies that you could do, or other things that you could do to titrate what pressures and other things you need. What else could they do? Yeah,
so I apologize. Probably it's my fault for being a little unclear. So with post-polio and other neuromuscular conditions, sometimes people have sleep apnea that's not necessarily related to neuromuscular weakness. Sometimes it is, but sometimes it occurs somewhat independently. And certainly in those cases, the breathing tests, all the standard breathing tests may be perfectly fine, and a sleep study is certainly indicated. So sort of in my algorithm, I often say, okay, if somebody has clear evidence of respiratory muscle weakness, I don't necessarily need to do a sleep study to show that they're hypoventilating at night. But if the breathing tests look normal, and people are complaining that they're not sleeping well, or they're tired during the day, or they're having headaches, I would certainly say, yeah, you need to do a sleep study. I think the second part of that question was, how should non-invasive ventilation be adjusted? And it's a complicated issue that's certainly open to a lot of debate. Some people will say a sleep study is the best and easiest way to make those adjustments. Some people will say you need to come into a hospital and be observed overnight, and we can adjust the ventilator through the night and come up with settings that seem to work well. My approach frequently, and depends on the patient and the underlying disease, is to pick some empiric settings, say, sort of based on a patient's size, body habitus, lung function, start off at a point and say, let's try it out, try it in the clinic, make sure it's comfortable, see what sort of volumes people can generate with it, have them go home and use it, and you can get information from the machines and look and see what sort of volumes people have had, do follow-up measurements of CO2 and see if those are coming down, see how the patient's symptoms are, and adjust it from there. So part of it depends on the patient, part of it depends on how urgently it's needed. A lot of times I try to be proactive and start it before people are really terribly symptomatic or in any urgent need, and then you have certainly more time to make adjustments and less urgency to say, okay, hurry up, get in the sleep lab or come into the hospital. So hopefully that addresses the question.
It does, and that's the way they've handled me since then. I haven't had any more, but the pressures and other things have changed according to my symptoms. The other question might be simple, and because you mentioned vaccinations, I recommend that we all recommend everybody get a flu vaccine and the Pneumovax, but I've heard that with the swine flu, most of us who are over 70 or over 60 probably don't have to worry about it because we probably are already immune. What are you recommending it for your patients, though, with ALS?
Yeah, so it's a great question, and I think it's still evolving. So certainly, I think as most people are aware, there's been a shortage of H1N1 or swine flu vaccines. So the CDC has recommended that high-risk patients, so essentially patients with some underlying medical disorder who are under 25 ought to be the first group to get it. And that's what we've been doing. But I think ultimately, and you're right, it's preferentially affecting younger people, and people who are over probably 60 are at much less risk. But ultimately, I think if the vaccine gets to a point where it's more widely available, I think anybody with underlying respiratory compromise ought to get it.
Yes, sir. I'm post-polio, and you're so knowledgeable. I want to ask this of you. It might not be appropriate at this time. In the last 20 years, I've doubled my weight, and I was in an iron lung. My breathing has always been my major problem. I'm on a BiPAP now for 15 years. Just went on oxygen a year and a half ago. Could my weight be a whole bunch of this problem, or do you think it might just be the post-polio?
You know, it's hard to know how much of a problem it is, but certainly increasing weight will put more of a load on the breathing muscles and make it harder. So.
Hello, thank you. Oh, in the center. Thank you. I have a question regarding newer types of ventilator, non-invasive ventilator that's coming out from Respironics. We have had the traditional BiPAP ST type of ventilator, as well as recently there's been AVAPs, which is a volume-targeted assisted pressure support. And I had been diagnosed with ALS for last 4 years, almost 4 years. And then for the first 3 years, I've been on BiPAP on a BiPAP ST, and with a pressure setting and a backup, right? And it's been going great. And then after 3 years, I switched over to AVAPs. And so then with the volume target, what I was experiencing was that when I had these spasms in my diaphragm with the AVAPs, what it seems to be doing is trying to deliver the volume with the higher pressure. And then that caused what other doctors told me, it's called aerophagia, which is swallowing or redirection of the air into the esophagus, into stomach, and causing painful distension. And so what happened is that after this was happening, I switched over to BiPAP ST, which I was more comfortable with. And then eventually that kind of resolved the problem. But I just wanted to ask your opinion on these neuroventilators. What is your thoughts on AVAPs as opposed to traditional BiPAP? Thank you.
So great question and a great segue, because I know Louis Boitano is specifically going to talk about both aerophagia and AVAP. So if bear with me, I'm going to defer to the next talk.
I have a question about how often can be done a sleep study. My son have DMD, and it's amazing how they discover something just by looking at him. It was a normal routine schedule appointment, and everyone was looking at him like tired, and everyone was, "What happened to you? What is happening?" And I'm just tired and tired. For me, it's normal because I'm with him every single day. So other people can see better than me. But to avoid these kind of risky things, because he have high levels of carbon dioxide, just looking at him, the doctor told me we need labs. So we're going to try to find what is happening with him. So after we have the result, we have discovered that his numbers increase really big. And then they try to adjust the BiPAP machine from 7 to 15 to 7 to 24. And I know it's really high numbers, and we are still dealing with some issues, but I can tell you by now that this is a little thing. But my question is, how often can be done the test to just avoid problems?
Yeah, so I think if I understood the question, it's how frequently should sleep studies be done? It's a great question. So I know my pediatric pulmonary colleagues tend to do them about once a year. I tend to do them a little less frequently, 'cause often by the time I'm seeing the patients with Duchenne muscular dystrophy, they're sort of often they're on a stable ventilation regimen and doing reasonably well. There's no official statement on how often they should be done, but I think a common position is sort of once a year. Certainly more often if there's problems arising, like you're having trouble adjusting the ventilator or patients are continuing to have symptoms. Less often if everything seems to be going very well.
My son has SMA type 3, and he's 3.5, and it was suggested to me by a friend that I get that, we see the pulmonologist and get a baseline established. And I was told that we'll discuss it when he has pneumonia and is in the hospital. So I wanted to ask you if you would recommend establishing a baseline that young, and what specifically to ask for to establish a good baseline going forward. So I know he already has some dysarthria, so there's definitely some, tongue muscle issues, and I don't know if that, I wouldn't know if it was causing sleep problems.
Yeah, I definitely think your friend was right that you want to look for problems early on and establish a baseline. So I think it's important to find a pediatric pulmonologist who is knowledgeable about neuromuscular issues and SMA. Certainly a lot of the tests that I spoke of are not relevant for a 3-year-old. They can't do, generally sort of at age 6 or so, you can start to do some of the pulmonary function tests, but you can certainly measure saturations and CO2 levels non-invasively and examine children, and sleep studies can be useful. So,
would you recommend anything? I mean, so far all we did was a pulse ox, which is standard. But would you recommend any specific non-invasive measurements to establish a baseline?
Yeah. So I'm not a pediatric pulmonologist, so it's a little. I'm not used to dealing with some of those issues, but certainly you can measure CO2 levels non-invasively, and probably a sleep study if as you said, if there's issues with the palate and snoring and disrupted sleep and things of that sort.
Okay.
Doctor, do you know if core strengthening exercises can help alleviate respiratory fatigue in people with PPS?
Another excellent question. So whether exercise can help. It's one of those things that there's a little bit of data on to suggest that exercise is probably beneficial. Certainly range of motion is important. So if the core muscles get weak, people tend to develop a hunched over posture, which impairs the ability to expand the lungs. So I generally recommend physical therapy with some directed exercise.
Just for your information and the information of the audience, I've been working with a physical trainer for about almost a year now, and I have less fatigue, more stamina, and my balance is better. So I'm a very much of an enthusiast and an advocate of it.
Yeah, no, I agree. I find exercise for patients to be helpful. The one thing to caution is, depends on what the underlying disorder is. There's some evidence in Lou Gehrig's disease that overexertion and too much exercise can actually be detrimental. So every now and then we get former bodybuilders and athletes who say, I'm just going to train myself right through this disease and want to keep lifting weights. And we say, well, you know, exercise is good, but don't overdo it.
Doctor, could you tell, sort of in a one-sentence answer, that I can relay to other people why you do not give oxygen to post-polio people in the hospital or an ambulance or something like that? Just a quick sentence that would say it simply but not really hard.
Sure. That's, I'm not sure I'll succeed, but giving extra oxygen can actually suppress breathing. And so if the underlying problem is that somebody's not, that with post-polio or other neuromuscular issues, if the issue is that they're not breathing enough to begin with, and you give them something that's going to suppress their breathing, you're just going to make the problem worse.
I noticed on your chart that you mentioned difficulties with phlegm and secretions, and I want to know, are these a symptom of more respiratory weakness, especially if they come at night?
So they can be. Sometimes with ALS and other disorders that affect the bulbar muscles, people have a lot of trouble just handling saliva, and so sometimes it's hard to know when people complain of congestion, whether it's secretions that are just building up in the mouth and throat, or whether it's truly secretions that are in the lungs and airways. But certainly, if somebody's having symptoms where they feel like they have mucus and secretions that they're having trouble coughing up, it's worth moving on to efforts to clear those out. Mm-hmm. Mm-hmm. Yeah, so you know, it certainly could be, and then, as I said, there are tests that you can do to sort of get a sense of how good expiratory function is, and see if that's really the issue, or if it's more just sort of local secretions in the upper airway. They can. A little less common, and they're certainly just very troubling and difficult to treat.
Hi there, post-polio survivor here. I got it 45 years ago overseas, and I have difficulty breathing, swallowing, the whole 9 yards. And I have diabetes, high blood pressure, and recently I'm supposed to have a thyroid surgery. I've got nodules, and I'm terrified of that. As it is, I'm sleeping sitting, and the BiPAP machines and CPAP machines did not work for me. What kind of problems am I supposed to look forward to having this surgery? And what are your suggestions?
Sure. So, you know, you're right to be concerned and try to anticipate potential problems. Part of the issues are, you know, depending on how severe the respiratory impairment is, we always, as Dr. Sheehan said, the anesthetic agents can sometimes worsen problems, so you need to make sure the anesthesiologist is aware and takes that into account. Oftentimes when people, and there's often these issues about should somebody get general anesthesia in which they put in an endotracheal tube or a breathing tube in and you're completely out, or whether to try to do surgeries under more lighter sedation, and challenges with, if somebody is on a breathing machine, getting them off after surgery. So these are all things to sort of talk about with the anesthesiologist, with the endocrinologist, or whoever's sort of evaluated the nodules, and a pulmonologist to try to work out a plan for what to do after the surgery. So it's really, usually it's the immediate post-op period that is most challenging. And if non-invasive ventilation, if it's felt that you need non-invasive ventilation and it has been working, again, it's probably time to sort of put your head together with the pulmonologist and figure out why isn't it working and what can be done to make sure you're safe after surgery.
I'm a post-polio patient, and I've been on a BiPAP machine for several years, and then just recently they added an oxygen supply to it for nighttime only. You think that's appropriate based on what you said earlier about oxygen levels?
Yeah. So the next sentence about the oxygen is that if you're being ventilated adequately, the oxygen shouldn't necessarily be any problem. And presumably, somebody saw that your saturations were low and felt that you needed it. So the question is why were they low? Is there some other cause? Because by itself, problems with ventilation, as long as the hypoventilation is treated with the ventilator, shouldn't cause problems with oxygen. But if there's something else causing it, then sure, oxygen is often needed.